Dr. Van Dyke. I'm going to go through the comprehensive diabetes care handouts with you so that we can better prepare you for your first visit to the office. We're doing these handouts by video ahead of time so that you can write down your questions, and when we actually get to see you face to face, we can focus on just the details that matter to your specific case. So there's a lot of documents to go through. Typically it takes about 25 minutes. This is the type 2 diabetes handout, and you'll be given a hard copy of this when we see you. What I want you to know first is that this is an amazing time in history to have a diagnosis of diabetes. This is not your grandma's diabetes anymore. There are so many new medications and technology that make your life easier and give us better outcomes in the long run. A lot of these medications are oral, and a lot of the technology really relieves the burden of day-to-day diabetes care. Before we get into those details, let's review what does a normal blood sugar look like. These are blood sugars in people who do not have diabetes. When you have your blood drawn first thing in the morning, that blood from the vein should not have a blood sugar any higher than 100. When you're fasting overnight, your blood sugar should be in the double digits. Similarly, if I gave you 50 grams of glucose, what we call a glucola, like what women will have to drink when they're having gestational diabetes testing in pregnancy. If I gave you that and I measured your blood sugar by that same vein 2 hours later, in a normal person, that number is going to be less than 140. The hemoglobin A1C that we're all very, very familiar with should be under 5.7. Some labs might give you a reference range of 5.8, some might say 5.6, but in general, it should be less than that. Anything in that 5.7 to 6.4 range is considered pre-diabetes, and numbers that are higher or at 6.5 or higher are considered actual diabetes. What I need you to know about that pre-diabetes phase is that by the time we have these really subtle elevations in blood sugars that give us a slightly increased A1C, we're already looking at damage to probably about half of the cells in the pancreas that produce insulin. And it's working like crazy to keep up with the demand for insulin, but it just quite can't get there yet. So the goal is always to really be aggressive about lifestyle intervention and using certain medications in that prediabetes phase, because we want to either reverse that situation or extend prediabetes as long as possible to prevent more damage down the road. As we kind of touched on, diabetes is an inherently progressive disease, and I'll reiterate that early and aggressive interventions buy us more health and time in the future. It's important that we are just as aggressive with blood pressure, cholesterol, and bone health, because all of these things are interrelated and make up diabetes comprehensive care. The method is about making systematic long-term changes. And think about it, if we're nailing it 80% of the time, then that gives you some flexibility, some padding, because life happens. You go on vacation. There are holidays. There are birthdays. You get invited out to dinner and have a good time with your friends. And so it's not about denying you any facets of life. It's about understanding how to mitigate everything. And when you do decide you're going to have a holiday or you're going to eat the thing that you normally don't eat, that you're able to handle what happens with the blood sugar, and then we get ourselves back on track the next day. So because of the advent of these different kinds of diets like paleo, ketogenic, gluten-free, there are tons of food and cooking resources available, and this just helps underscore that lifestyle is the cornerstone of your success. There is absolutely no drug that I can give you that is going to give you as much of a payoff as you optimizing your own lifestyle. So just like I said, it's not about elimination, it's about shifting perspective and adjusting your approaches, being able to anticipate your needs, especially in the situation where something's not going right. So fundamental principles of glucose control. How do we win against diabetes? Number one, bring your data to every doctor's appointment. This is easier with the use of continuous glucose monitors because we can download that information and view it from the online portal. But I can't make decisions about what's the next best move unless I have the data in front of me. We're otherwise just flying blind. I would like patients to avoid naked carbohydrates. What is a naked carbohydrate? Let me give you an example. If you had a piece of Wonder Bread just by itself, you just ate the bread plain, that is a naked carbohydrate because that is sugar going into your body without anything else to try and slow it down. What slows down sugar absorption? Fat, fiber, and protein. So when we avoid naked carbs, we clothe our carbohydrates in some fat, fiber, protein, that helps everything smooth out. We don't want to see spikes in the blood sugar chart. We know that patients who succeed in reducing their body weight by 5 to 10% will dramatically improve their own insulin sensitivity. And when we're in the early phase of disease, especially that pre-diabetes phase, people absolutely can reverse and resolve their diabetes. Okay? Moderate exercise is a tool by which you can both reduce your body weight and improve your insulin sensitivity. And a half an hour of moderate exercise will actually impact your insulin sensitivity for several days. And this is the value of your Fitbit or your Apple Watch or your Motive Ring. So every time you choose the stairs, the bicycle instead of the car, or the gym instead of the couch, this is actually going to translate to money in your pocket. But let's define moderate exercise. That you don't have to be a marathon runner, okay? Moderate exercise is walking or jogging 1 mile in 12 to 15 minutes or some equivalent activity that's about the same. So it's not even as bad as doing the 12-minute run back in junior high and high school. So I have prediabetes. I've had it now for about 5 years, and I have kind of figured out, mostly through trial and error, what products help me handle my glucose control. So check Target, Costco, Walmart, and Amazon for all these best prices. My favorite apps right now, there's one called Figwee, and it's awesome because you can look up the food you're going to eat, and it's going to show you a picture of that on your plate. Then there's a slider bar on the side that will help you adjust the serving size that you're looking at on your plate, and it will tell you calories, fat, carbohydrates, etc. It'll do the same thing for wine, beer, any other alcohol. MyFitnessPal, also really helpful for logging calories, understanding portions, and carbohydrates. When it comes to choosing bread, again, you want to choose things that have whole grains, have fiber in them. So what works for me is Nature's Own. I prefer the Life Wheat Plus Protein or the Wheat Plus Fiber. They also have one that's called Low Sugar. Cereal, there are cereals that are actually really high in protein. I haven't tried them myself. There's one called the Cereal School. I'm actually interested in knowing people's feedback about this. But otherwise, if I'm going to eat something like that for breakfast, I stick to steel-cut oatmeal because it's just a whole grain. And I make sure to pair it with some toasted nuts to further slow down the absorption. Quest and Real Good both make low-carb frozen pizza. If you're looking for any kind of fruit spread or jams, Polaner and Welch's do make these products without adding any sugar. That means that the only sugar that's in that jar is the sugar that comes in the fruit from the vine. About other sweeteners, you know, there are lots and lots of artificial sweeteners or sweetener alternatives on the market. Agave syrup is one, stevia is one, swerve is common because you can bake with it. That's actually a sugar alcohol called erythritol. There are other sugar alcohols like xylitol is another common one. And then there's monk fruit, which I know is popular with a friend of mine who is a type 1 diabetic. Nuts and nut butters, you want to get them without any added sugar, but these are gold because you get the plant-based fats from the nut and you get the fiber from the nut as well. Pure protein bars, one protein bars are both very good, pretty balanced in the carb to protein ratio. Premier protein shakes I really like, again for the same reason that they have kind of a 1-to-1 ratio between carbs and protein. And it's not that 1-to-1 is a magic ratio, that just happens to be a number that I have figured out over the years that keeps me from having spikes in my blood sugar. There are lots of alternative pastas that are high in fiber. Shirataki Miracle Noodles. Weight Watchers has a brand called Skinny Pasta that's made of konjac, which is very closely related to these miracle noodles. And there are others made of banza, edamame, and adzuki. There are lots of different flavors and textures, so you have to experiment with them and find your favorite. In terms of yogurts, Dannon Light and Fit, Greek yogurt, Siggy's Skyr is my favorite, actually, and they do make a plant-based version as well. Gabriella's Kitchen is a frozen food brand that offers skinny pasta options and low-carb frozen meals. Real Good is another brand that makes some enchiladas that are pretty palatable. You know, soft cheeses, lean meats, fatty fish, these things have essentially no carbohydrates in them, and so you can really run with it. Strawberries, blueberries, raspberries, blackberries. For some reason, in my personal experience, I have fewer problems with higher blood sugars when I eat these whole foods compared to other fruits. So start there if you like fruit. Bob's Red Mill is a flour brand, and they offer a number of different kinds of flours. One of them is a low-carb baking mix that is full of fiber. Let's talk about the correct way to rescue a blood sugar that is under 70. Think about when this happens to you, you usually feel like garbage, and it's really hard to do this in a controlled way. So the first thing that needs to happen is that you have access to rescue everywhere. Get a bottle of glucose tablets. They're over the counter. You can get a bottle of 50 for like $7. Walmart, Amazon, Target, find the best deal. Each glucose tablet is about 4 grams of glucose. And so we need to eat 16 grams of glucose. And then the hard part is this, sitting on your hands for 15 minutes, which is an eternity when you feel like this. But you wait 15 minutes before rechecking the sugar because you gotta give your body a chance to absorb it. So 16 grams of glucose is the same as 4 of those glucose tablets, or you can have 6 ounces of apple or orange juice. This is not very much juice. Keep that in mind. Or if you don't have any of those things, you can put 4 to 5 packets of sugar in water and drink that. If after 15 minutes your sugar is still less than 100, repeat that first step until the sugar is over 100. Once your sugar is over 100, it's time for a small mixed snack. A mixed snack is going to have all of our macronutrients in it. It's going to have some carb, it's going to have some fat, and some protein. And that's going to maintain your blood sugar in the normal range going forward instead of letting it drop back down. An example of a small mixed snack might be some Greek yogurt with a lot of protein in it. Maybe you have some nuts in that. Or maybe you have a half of a turkey sandwich that has some lettuce and tomato and mustard on it. The number one principle in rescuing blood sugar correctly is to avoid overtreatment. And it's so easy to overtreat because you feel badly. We never want to be chasing a blood sugar of 300 because that's always a losing game. Once you have gotten your blood sugar balanced back out, I want you to think about what may have caused your low blood sugar. Did you forget to eat a meal? Were you late to a meal? Did you exercise? Did you miscalculate how much insulin you needed? We need to find the pattern and correct that underlying cause. And I want to add this note that chocolate is not a good rescue source for blood sugar because it does have a lot of fat in it. Will it make your blood sugar go up? Yes, absolutely. Is it going to do it right now in the next 15 minutes? No, it's going to do it in like an hour. All right, so let's say you're on insulin. How do you handle your insulin? Because when you leave the office, we put you on your insulin regimen, and we know that that's not going to be your forever dose. The overwhelming majority of people need to make adjustments up or down on their insulin. When you're in the office, we are going to go through this part again with each other because there are some blanks we need to fill in here. I'm going to identify for you what your target fasting morning blood sugar is, what is perfect for you, and that's individualized. Then we're going to pick 2 days of the week that are not next to each other. For example, Monday and Thursday. And while you're going to be checking your blood sugar every day like you normally do, it's the Monday and the Thursday that matter for changing anything about your basal insulin. So those are the days of the week you're going to make adjustments. We don't want to make adjustments every day because it takes basal insulin a long time to work. So we'll decide if your fasting blood sugar is a certain number, whatever is the right number for you, then that will be the trigger to increase your basal insulin. And the reverse is true. We'll decide what is the threshold for you to trigger a reduction in your insulin. This is a process we continue doing on Mondays and Thursdays, slowly, steadily, because we don't want to overwhelm the body and drop blood sugar like a rock. And we do this until you get to your sweet spot, your goal range. How do we deal with the mealtime insulin? This is the short-acting stuff that you take right before you eat. And we will set your 2-hour post-meal goal. And the nice thing about mealtime insulin is because it acts quickly. It takes like 15 to 30 minutes to act, so we can make changes to that all the time. So we'll set the thresholds again. If your 2-hour post-meal sugar is above or below these certain numbers, then that's what's going to trigger you to make a change to how much mealtime insulin you get. Now, what about an emergency plan? This is a really big deal. What happens if you're in a situation where you've completely run out, or maybe you're traveling and you've lost your insulin? What do? Number one, you call the pharmacy. Do you have a refill? If so, get it. If you don't have a refill, you call our office and we will send it. If for any reason you cannot reach somebody to refill your insulin, this is the ultimate emergency. It's the middle of the night. You're in some other state. You don't know what to do. You're going to go to a pharmacy. You're going to tell the pharmacist that you are diabetic and you require insulin. You have run out of your insulin. Walmart will be the best place to get a good price on this stuff. You're going to ask the pharmacist to give you a product called NPH insulin, or brand name Relion, as well as the needles and syringes over the counter. In the state of Texas, you do not need a prescription to do this, okay? We will set during your visit how many units of the NPH insulin you would need to give yourself every 12 hours to keep you out of the hospital. We don't want you to land in the ER with DKA, okay? Anyway, this is a Band-Aid because we don't want you to be on NPH insulin forever. We want you to be on it until we can get you your usual insulin back, okay? It's all right if the blood sugar is not perfectly controlled. It's just a temporary stopgap, All right. So for the ladies who are listening to this session, we need to talk about family planning. You need to know that about half of all pregnancies in the United States are unplanned. There are significant risks to both mom and baby when an unplanned pregnancy occurs in the setting of diabetes. So it's absolutely fundamental for everyone's safety that we plan for conception appropriately. If you are not ready for pregnancy, there are tons of options for reliable contraception. Intrauterine devices, progesterone implants, contraceptive pills, injections, rings, permanent sterilization. It all just depends on what your specific needs and preferences are. So getting pregnant is fine, but getting pregnant by accident is not. All right. What can I do to make my life easier and get better control? Number one, always take those medications as prescribed. Do not miss doses. Number two, bring us the data. We got to see your glucometer, your CGM, or your glucose log at your appointment. Using the sensor is awesome. So there are a number of sensors on the market now. Abbott makes one called the Freestyle Libre. In fact, there's a new version of it, the Libre 2, which automatically will check your sugar every 60 seconds. You wear this device for 14 days. It costs about $35-45. You read the glucose with either the scanning device, which you have to pay separately for once, or you can use the app on your phone, both Android and Apple. Medicare and commercial insurance pays for the Abbott Freestyle Libre. Dexcom and Medtronic are both bigger companies that have continuous glucose sensors and that integrate into insulin pumps. These are much more expensive, but they also can be dispensed in the pharmacy. The regular Freestyle Libre will not alert someone to a low blood sugar, but the Dexcom and Medtronic devices absolutely will let the patient know if they're on their way to a low. The new Freestyle Libre 2 will actually do this as well. So technology is getting better. Medicare and commercial insurances pay for these devices when we meet certain criteria. Eversense is the newest sensor. In the United States, it's approved to be worn for 90 days. It's a small fiber capsule that is implanted under the skin, and it communicates with an adhesive transmitter that sticks over the top of it. It will vibrate to let you know if your blood sugar is changing. And as always, you deserve to have resources to utilize when you have questions or you want more. I think that many people do not know that the YMCA offers a diabetes prevention program, and there are actually a number of benefits patients can get when they use this. The American Diabetes Association and the Centers for Disease Control are great resources for general information, education, recipes, even. National Institutes of Health and the Mayo Clinic are both informed, peer-reviewed, accurate sources. Now we're going to move on to the next one. First, let's talk about the facts about heart disease. Absolutely number one, most important thing, heart disease kills more people in the United States than all cancers combined. There is actually one death, not just a heart attack, but death by heart attack every minute in this country. So we're well over 500,000 deaths per year for something that is almost always preventable. Half of people who have a heart attack will not even make it to the emergency room. Once you get to an emergency room, modern cardiology is extremely good at prolonging life, and we have varying degrees of ability to preserve function of the heart. Every single one of us in the United States is born with atherosclerosis. That's clogging vessels. Those are plaques that are deposited inside the vessels. It actually starts when we are in utero, and it is related to the Western diet that our mothers consume. Heart disease is preventable and fully treatable. There is essentially no reason why anybody should be having heart attacks in the United States. Vegan and Mediterranean diets are the only diets that have been shown to reduce mortality from cardiac causes, and the entire process of plaque formation of atherosclerosis is mediated by inflammation. So controlling inflammation is our big gun. We can see certain plaques on radiology images, mostly in the aorta, because the aorta is this huge hose you've got going all the way down your torso. But if you can see a plaque in that one spot, you're guaranteed to have plaques in many spots, and the majority of those we cannot see. The top two risks for developing heart disease are age, because age is the number one risk factor for just about everything, and being male. Males tend to not care for self nearly as well as females do. Now, I want to talk to you about things that you probably hear frequently that are not actually true about heart disease. The first one is, I'm too young to even worry about heart disease. That's a disease of old people, and that is absolutely not true, because we know we are developing plaques while we are still inside of our mothers. We see it as an elder disease because it gets bad enough by that point that those are the patients who are rolling up to the ER having heart attacks. But when we intervene on people in their early lives, then they don't roll up to the ER with heart attacks when they're in their 60s, 70s, and 80s. Another fiction. My cholesterol has never been high, like over 100, so I don't have to worry. Actually, when we study the people who are having heart attacks in the United States, the average bad cholesterol level is 90. So, good cholesterol. Here's another fiction. Good cholesterol is so high that it makes up for my bad cholesterol. Now, you're not wrong that the good cholesterol, or HDL, is a nice pipe cleaner. But not all HDL is created equal. So it only pipe cleans if that particular molecule is working properly. So far, we have no way to know what the functionality of HDL is, so we cannot count on it to save us when the bad cholesterol is high. A fiction that is commonly thrown around on the internet is that statins cause diabetes. Now, we know that statins are known to accelerate the onset of diabetes, but this doesn't happen in people who do not have prediabetes or have strong risk factors for diabetes. You won't find somebody who's otherwise lean with proper insulin function suddenly becoming diabetic. Okay, and what is the difference between people who are on statins and those who are not? The difference is only about 2 years between developing diabetes. There was a lot of buzz about statins causing dementia some years ago, and this was soundly disproven in 2013 by Johns Hopkins with a large review of many studies that examined over 23,000 patients. Why? Why is it not true? Well, it turns out that statin medications are extremely powerful anti-inflammatory medications. So that protects the vasculature in the long term and reduces our risk of dementia that is caused by tiny vascular events. This is common. I can't tolerate taking statins because they cause muscle pain. So interestingly, when we blind and randomize placebo-controlled trials, there's no difference in the onset of muscle pain whether the patient gets the statin in the study or a placebo. But in the cases where patients do have a problem with that muscle pain, even a small dose of a potent statin a few times a week can have an important impact on preventing heart disease. So for example, rosuvastatin, what they used to call Crestor, is probably our most potent statin medication, and there's a handful of patients that they don't like to take it because it does cause their legs to ache while they're trying to sleep. So what we do is we've knocked it down to 5 milligrams, and they take it on Fridays, and they try and take it again on a Tuesday. And so far they've been doing well. There also is another brand of statin, pitavastatin, that claims to have no muscle pain side effect. So there are options still. Another fiction, I'm a very heavy exerciser. I do marathons and things, so my heart is fine. And what we know is that so much of heart disease is actually genetic. Even people who look amazingly healthy and fit can have nasty heart disease, and that's probably due to a hereditary disorder of their cholesterol metabolism. So we absolutely got to screen everybody. In a related facet, the idea that heart disease is genetic and so we're powerless against it is also false. We have so many tools, medications, technology to identify early heart disease and regress the plaques. That includes statin medications. There's another medication that's a cousin to statins called Zetia that's very effective. Together, when we give powerful statins with Zetia, we can see a 75-80% reduction in the bad cholesterol. There's a new class of medications called the PCSK9 inhibitors, popularly known as Repatha, that can also be used to significantly reduce bad cholesterol. The lifestyle and the dietary guidelines, this is still a cornerstone of your success. There's substantial data that shows the plant-based and Mediterranean diets reduce death by cardiovascular cause. Coronary artery calcium scores are a really simple, quick diagnostic test we can use to understand if you have hard plaques or not. And we have lots of blood tests for cholesterol, inflammatory markers, genetic disorders. So how would you know if you're at risk? Well, we ask you, has anybody in the family had a heart attack? Did it happen early, like under age 55? Has your total or your bad cholesterol ever been high? Do you have other diagnoses like prediabetes, diabetes, high blood pressure, rheumatoid arthritis, HIV, cancer, kidney disease? All of these things are inflammatory and they lend themselves to making atherosclerotic plaque. Do you eat saturated fats? That's animal fats, meats, butter, lard. Coconut oil is a plant-based version of a saturated fat. Basically any fat that's solid at room temperature. Are you overweight? Are you obese? Have you ever smoked in your life? And one that I don't have on this form but should is, do you have sleep apnea? What is a coronary artery calcium score? We touched on this. So it's really quick and dirty. It's non-invasive CAT scan of the heart. There's no dye, no contrast, no IV. The radiation exposure would be the same as a mammogram, or if you're somebody who has lived at high elevation, 5,000 feet or above, if you were to live there for 3 months, that's the same amount of radiation. I lived in Albuquerque for 2 years at about 5,500 feet, and nobody was fleeing the town for concern of radiation exposure. This particular type of x-ray is synced to your EKG. It only takes about 10 minutes. This is usually a cash pay thing, and the price ranges around here from about $50 to $150, just depending on the place that does it. Some insurance covers it. It's just a really hit and miss. The radiologist and the computer calculate a standardized score of plaque formation in those teeny tiny vessels in your heart. And we have long-term data that shows us when that coronary score is 0, the odds of a cardiac event are less than 1% over the next 5 years. But if any coronary score is higher than 0, regardless of how old you are, whether you're 20 or you're 70, this correlates with significantly higher odds of cardiac events over the next 10 to 15 years. The higher the score, the higher your odds. If a score is higher than 100, these are the most severe cases and we need to be super aggressive. That's a situation where we talk about combination therapy. Medical therapy is extremely effective at minimizing bad cholesterol and reducing heart-related mortality. So what if I send you for a coronary score and your score is 0? That's good news. Your risk of an event in the next 5 years is minimal. We should check it again in 5 years because remember that age is our #1 risk factor in heart disease. And what if the score is little? What if it's like 1? I want you to know that any score over 0 matters. But when the score is less than 10, it's very reasonable to optimize lifestyle and diet and then retest in 5 years. Again, I always provide you resources because when you want to go learn stuff, you want to be able to get it from reliable places. National Heart, Lung, and Blood Institute, Mayo Clinic, the CDC, and the Heart Association all have valuable information, and the Heart Association has good recipes as well. So bones are super alive. They are constantly remodeling. They're extremely active when we think about cell metabolism. And they remodel in response to the forces that are applied to them. So think about bone remodeling like the process of repaving a road. So you have cells that are going along and chewing up that old asphalt or your bone matrix. Then you have other cells follow behind them and lay down new asphalt. As we age, or as we get more inflammatory diagnoses, the cells that lay down new bone slow down more than the ones that break down the old bone. So you get this net increase in bone breakdown that eventually produces osteoporosis. Like we mentioned, remodeling of bones is affected by other diseases. Diabetes is one of them. COPD, rheumatoid arthritis, and there are a number of medications that will affect bone remodeling, like steroids, chemotherapy, drugs that are used to block testosterone when someone has prostate cancer. Smoking and alcohol consumption are also major inhibitors of bone metabolism. So stop smoking and limit alcohol to 2 drinks per day or less. How do we know if someone is at risk for bone problems? Well, we ask questions just like we do for the heart disease. If women in the family have had osteoporosis or broken hips, if you smoke, drink alcohol, have any other inflammatory diseases like rheumatoid arthritis, ulcerative colitis, lupus, Crohn's disease, COPD, diabetes, obesity, cancer. If you have problems with low vitamin D, if you've lost height or you notice that your posture is getting worse or you have this nagging pain in your neck or your back. If you've had certain types of non-traumatic fractures, what do I mean by that? I mean you're walking down the street minding your own business and you trip and fall from that standing position and then you break a hip or a vertebra. That's a big deal. If you've had to take steroids like prednisone, dexamethasone in high doses or for long periods of time to manage other conditions, if you had an early menopause or you have a condition that causes low testosterone, also if you've been critically ill or you've been bedridden for any reason. So what do we do about these disorders of bone metabolism? Well, everyone should have adequate calcium vitamin D in the diet, preferably in the diet, or take a supplement because the body's got to have those building blocks in order to do its job. Because bones remodel in proportion to stress that is applied to them, we recommend weight-bearing exercise like you would do anyway for your heart health. That's, low impact strength training, walking, jogging, stair climbing. Regrettably, my favorite activities, swimming and cycling, don't really count very well for weight-bearing exercise. So I have to do other stuff on top of that. We also treat osteoporosis with medications like Fosamax or Boniva. Their job is to slow down those cells that break down that old bone so that those cells that lay down the new asphalt can catch up. This is a slow process and it takes months to years to see the effect. And then there's another drug. There's actually a class of medications. Forteo is just one of them, which boosts the activity of those cells that lay down the new bone, and it does work to heal fractures very quickly. We see this medication or this class of medication actually used by professional sporting teams to get their players back to play faster. But how much calcium, vitamin D do you even need? That does depend on your age and your general health. We want that vitamin D level in your blood to be between 20 and 50. I err more toward between 30, 40 or so. I don't like it over 50. We know we have problems with toxicity when numbers get higher than 50. Getting calcium from the diet is best, but the bottom line is that you need it, so supplement if you have to. The average American diet, by default, will get about 600 milligrams of calcium per day, and each serving of dairy confers about another 300 milligrams. So if you regularly consume milk, cheese, etc., you are getting plenty of calcium. You do not have to have dairy sources as calcium, and I will provide those lists to patients both online and in the clinic. This table 13 shows us by age and sex, male and female, how much calcium we need. And over here in this box, we'll go through this. What is your particular goal vitamin D level? So what if you happen to carry extra weight? How does obesity affect bones? Well, again, we've been disproven in the past. So let's consider a twin study, a hypothetical. Let's say you've got a set of identical twins and they both weigh 300 pounds, but one of them is a bodybuilder and the other one works at a desk all day. The bodybuilder is going to have better bone density and health, and that's because obviously he's doing weight-bearing activities that are building his muscles and constantly pulling on those bones. They apply stress to the bones and the bones remodel in response. That other twin is carrying a lot of weight, but with less traction. So when you combine that scenario with the inherently pro-inflammatory state of obesity, this actually impairs bone remodeling. What medications are available? Well, we have the class of antiresorptives. This is our Fosamax, Boniva, Prolia, Zometa. That slows down the old bone machinery so that the new bone formation can catch up. We have the anabolics. We talked about Forteo. Tymlos is another one, and there are a couple more nowadays. They work like a big boost to those cells that are putting down new bone. There is another class called sclerostin inhibitors. This is kind of a dense way to describe that they still lay down more new bone, but they also break down some old bone. So there's a newish drug called Evenity that does that. What risks are associated with treatment? For the antiresorptives, the Fosamax, Boniva, Prolia, these drugs are most famously associated with a condition called osteonecrosis of the jaw. This is rare, occurring in about 1 in 40,000 at the osteoporosis doses. It's really typically only seen in the higher doses of drug that are used in cancer patients. Nonetheless, we screen everyone for risks, such as oral surgery or tooth extractions, and I have only very rarely seen this complication. However, if you do develop problems with the jaw after an oral surgery, it would require immediate attention at an emergency room. The second famous risk with the antiresorptive class of medications are called atypical femur fractures and are more likely to occur when a patient has taken the medication for more than 5 years. Again, the incidence is about 1 in 20,000. The symptoms of these problems are nagging pain in the groin or upper thigh. We minimize the risk of these fractures by re-evaluating the risks, benefits, and alternatives to treatment when the patient approaches year 5 of treatment. For those anabolic agents, those powerful drugs that boost the cells that lay down new bone, these are very highly effective, but if you have had radiation therapy to the spine or there is a history in the family of a bone cancer called osteosarcoma, or when a patient is at risk for metastatic cancer, the risk outweighs the benefit of using these drugs. The second problem with using these drugs is that after you finish those 2 years of treatment, you absolutely must follow it by taking an anti-resorptive agent, or else we will lose the bone we built over the last 2 years. For sclerostin inhibitors, the newest medication available, it's not good for people who have had heart attacks or strokes in the last year. Treatment is for 1 year, and then just like the anabolic drugs, must be followed with an anti-resorptive medication. As per usual, I give you some resources for when you want to learn more and you need to be at a resource that is reliable and accurate. I recommend the National Osteoporosis Foundation, www.nof.org. Thank you for listening to this tutorial about diabetes comprehensive care. I hope that it was useful and informative for you. Please do write down your questions so that when we do see you, we can spend the time in our visit attending to your specific needs and your diagnosis.